Thank you, everybody, for joining us. This is Chadi Alraies coming to you from Heart Trending. This is our series every third Thursday at 6 p.m., talking about a topic related to cardiology, imaging, interventional cardiology, structural heart disease, what's new, what's technology available, and also what techniques, and also what is in the literature. I'm really privileged today with Dr. Evan Shlofmitz. I think he was maybe a medical student when I was a resident with that, but he made a phenomenal career in cardiovascular imaging. We learned a lot from him during conferences. He's director of interventional cardiology, interventional imaging at the St. Francis Hospital, the Heart Center in Roslyn, New York, and he's the co-director of one of the most famous courses happening online, also in person, for optimizing OPCI or optimizing PCI. He completed his fellowship in interventional cardiology at MedStar Georgetown Hospital, the university, and also he completed his cardiology as his interventional imaging cardiology fellowship at the CRF or Cardiovascular Research Foundation in Colombia. He did his general cardiology at Northwell. He was a chief resident before, and he is currently the chair of the Psi Ischemic Heart Disease Council, which is very important council. And I think the enrollment is now happening now for this council. He has more than 200 publication in peer-reviewed journal, and his talks are always phenomenal, very educational, brief, and impactful. Evan, thanks again for doing this for us. And what platform is yours?
Thank you so much. Thanks so much for the kind introduction. And, it's an exciting topic. And, I got to have a nice journey through the literature to try to come up with what's worthwhile to discuss today. So, as Chadi had mentioned, we'll discuss the year in review, coronary intravascular imaging publications. And for this, I kind of set as my task, all the data you're seeing, all the slides had to come. My rule was from a publication that was published in 2025. So it's all contemporary data, and it's all things that I think will either already has shaped the field or will be impactful in the near future. These are my disclosures. I work with most of the intracoronary imaging companies. So there's no better place to start than with the guidelines. This by far was the most impactful thing in intravascular imaging, and I think really for coronary interventions in 2025. So led by Sunil Rao, they updated the ACS guidelines in the US, and for the first time, it's a class 1A recommendation to use routine intracoronary imaging, and that's IVUS or OCT, and it's recommended for procedural guidance to reduce ischemic events. And they were intentionally, I think, vague in who should get this, and they left it as left main or complex lesions. And complex lesions, we know, is a very broad definition based on the clinical trials that really encompasses most of the patients that we're treating with PCI today. So now, class 1A recommendation for routine intracoronary imaging in all patients with ACS. So that was very impactful, and that I think shapes so much of what else we'll be talking about today. So the next thing that I think is a nice build upon the US guidelines with a 1A recommendation is where we are with intracoronary imaging utilization. And for so long, we've talked about this 10 to 15% use of IVUS and OCT. But I think it's really important for all the viewers to be aware that that's not standard of care in 2025 or now in 2026. And some of this best data we have from the group of in Michigan, BMC Squared registry, they've been reporting utilization of intracoronary imaging, and they've had a number of publications looking at the use of imaging. But this was a recent one led by Ryan Mader, which found that since they've used intracoronary imaging as a quality metric in the state of Michigan, all-comer PCI, you've had quarter-over-quarter growth in intracoronary imaging use, but it's now 44% statewide. So that's really remarkable. So way past the days of 15% imaging, 44% imaging in all-comer PCI. If you look in orange, the ISR is over 50% for in-stent restenosis. When you look at left main PCI, is approaching 80% in the state of Michigan. So Michigan's leading the way. And this really has set the bar for where intracoronary imaging should be really throughout the US. And as you'll see in some of the later slides, technology is advancing and our understanding is advancing, that hopefully it'll be easier and easier for the rest of the country and physicians all over the world to really achieve these numbers that are set by Michigan. And I will say, as a disclaimer, this was data, even though this was just published this past May, this is data coming out of 2023, and they've seen since then quarter over quarter growth. So I think this is just a start, and we'll continue to see impressive numbers with future publications. So,
But is there any comment from the paper itself or from your experience? What made this rise or jump in acquisition of this imaging, like jumping from 15 to 44?
yeah, it's a really remarkable growth in such a short period of time. I think that the biggest thing we can attribute, is hats off to the team from Michigan and BMC squared for making it a quality metric and reporting. It was as simple as they started in 2019, where there was this rise. They decided to use intracoronary imaging as a quality metric. So there's awareness and discussion, and just things like what you're hosting tonight is when you discuss something and bring it to the top of people's mind, people are more aware of it and they start incorporating it more. And with reporting came reimbursement too. And there was reimbursement, and reimbursement is a powerful tool to
Mhm.
drive utilization, I think. But I think the other thing that really happened around 2019, there was accumulation of data. There's, this randomized trials, Ultimate, IVUS XBL, Renovate Complex PCI. The snowball effect of this momentum of it's very clear at this point. There really isn't this. We used to have conferences, as you mentioned. When you were a fellow, I was in early fellowship. The debate used to be, should we image, yes or no, imaging versus the angio, or imaging versus something. I think it's settled now, and you see that in the guidelines. Intracoronary imaging leads to improved outcomes. That's clear. The data is pretty clear on that, and that momentum has spread, and people are aware of that. Particularly younger physicians grew up in training with intracoronary imaging, and I think that's helped shift the field. And then at the same time, some of which we'll talk about in the next couple of slides, is the imaging has gotten better. For the most part, most imaging software that's offered today is not the same software that was available in 2015. It's much, much better. And that makes it easier to use, easier to understand what we're looking at, quicker, better catheters, and some really exciting things happening in the world of intracoronary imaging that just make it where we can extract more information from it. So if something's easier to use, our understanding's better on how to use it, the data shows that it leads to better outcomes. We're not just talking about larger stents and greater expansion, less dissections, and it does all those things, but it's about patients live longer. MACE is better. We saw from the meta-analysis that nearly 50% reduction in mortality. So there's this accumulation of things that have converged, which is really what I think led to this utilization, and that will, I think, continue to grow before it plateaus. I can tell you in our lab, we had this rise all the way up to about 85%. And then from there, it's kind of jumped up into the low 90s, and that's where it's kind of plateaued. And that's where I think in a lot of places it will end up plateauing. So,
Also, there's a lot of courses happening as you like you OPCI, for example, going nationally, doing a junk with national conferences, and also off time educate other providers, I think, to understand and interpret what they're looking at, so they know how powerful this tool is.
yeah, no, thanks. It's important. You need to know what you're looking at. And courses, there's lots of hands-on courses and regional courses. Our group has led some, Dallas PCI, they've done a number of these courses, and it's key because we have them all over the country. If you go to this 1 day, 2 day course, understand the foundation, understand how to use the tools, at that point you're independent on Monday. When you go back to the lab, you know how to use the basics. And like anything, you get better the more you incorporate it. But the technology's gotten good enough that if you have a 1 day course, you can integrate the tools, and with some support, you can figure out how to incorporate it into your practice. And then once you're using imaging and you use it routinely, you get better and better. And it's a pretty short learning curve to be comfortable with it. And what we see is it takes a lot to get a physician to incorporate this and change their practice. But once they're using imaging, they never go back to an angio-guided PCI person. It just doesn't happen. You don't go from an IVUS OCT user to angio-guided PCI. So once you have the skill set, you're aware, and this changes your practice. It's just like with a heart team approach. You don't have people say that, look, I've been doing TAVR for 10 years now. I'm pretty good at this. I don't need to look at an echo and a CT. I'm going to just go in, see how tall the patient is, and guess what valve size. It's ridiculous, and it would never happen, which is what I think we've come around as a field and realized that angio-guided PCI is not optimal. And it's become where the standard of care for us, it's used in cases where anatomical complexity precludes intracoronary imaging, and that really, I think, is where it should be down the line.
Absolutely.
So, a couple of interesting things. This was a study. It just wanted to highlight some smaller studies that really had some interesting features, just some kind of rapid fire things. This is a study led by Rick Volberg, where he looked at, with intracoronary imaging, particularly with OCT, the identification of high risk plaque features and how that contributes to MACE. And he found the number of these features, and the more of these features, high lipidic arc, minimal fibrous cap thickness, thrombus, plaque rupture, are obviously associated with increased events. But what's important is these features are readily identifiable on intracoronary imaging. And if we identify it, we can do things to change this. And particularly my interest is on the impact of pharmacotherapy once we've identified a lot of these features as well. But he also, in further studies, showed that these high-risk features are associated with increased rates of major adverse cardiovascular events out to 2 years. And again, this is all in non-corporate lesions. And as you see, these are features that, like with OCT on image A, you can see from 9 to 12 o'clock, very thin cap fibroatheroma. This is high risk. That this may not be something that we're going to stent in the cath lab in modern practice, but these are things, antiplatelet therapy, PCSK9 inhibitors. You have the opportunity, if you recognize this, we can act on this and try to prevent their non-culprit MACE event down the line. So intracoronary imaging is critical in being able to identify that. And I want to shift gears for just a few minutes talking about AI, because that makes it even easier for us to identify some of these features. Some may be easy to recognize, but some of these may be difficult, particularly for people who aren't using intracoronary imaging on a regular basis. And with AI, the easier it is to identify, the easier it is for us to act on it and offer the best care for the patient. So this is not related to imaging. This is just on machine learning and AI, and it just highlights kind of the explosion in publications you can see in recent years, and there's growing interest in the role of AI. So this is a publication in one of the European heart journals that really highlights how AI is changing the game for intracoronary imaging. You no longer need to do an intracoronary imaging fellowship to be comfortable in what you're looking at, because thanks to AI, this rapidly in real time segments each cross section, and everything gets annotated. So everything can be labeled and color coded, essentially what we're looking at. And it's a great learning tool. As you go through intracoronary imaging, you get that immediate feedback from the AI of what we're looking at. But in real time in clinical practice, it's great because it helps guide you on decision making and how we address it. And you can see here there's variability in positive predictive value for different plaque types with AI, but the AI can quantify the arc, the thickness of different types of plaque. You can see segmentation with whether it's calcification, thrombus, lipid, and this is just helping to ease operator assessment of what they're looking at, but also in speed and rapidity and being able to interpret images. And here you can see an example with thin cap fibroatheroma, and the AI using deep learning can interpret which are the high-risk plaques, what needs to be addressed here. Here you see also the ability to detect stent struts and localizing stent struts. You see with the blue dots, they can localize every stent strut, which is helpful for this automation in determining is our stent adequately expanded. And This was another study led by Rick Wahlberg, who was very busy last year publishing. And what he wanted to look at is how does AI perform to expert readers and core lab readers with intracoronary imaging? And here he found that AI actually outperformed core labs in being able to determine and identify high-risk features like thin cap fibroatheroma. So I think this has a tremendous impact on us as operators in the near future because AI is being incorporated into contemporary intracoronary imaging. There's a number of systems that utilize AI, and this is going to continue to accelerate and I think improve the quality of the software that's available to us and what can be detected and I think will hopefully help to increase the utilization as well. So we've summarized in a recent JSky publication the AI that's currently available in intravascular imaging. These are the 4 systems today that are available in the US that offer artificial intelligence. The first was Abbott's OCT, as you see on the left. Boston Scientific was the first IVUS company to offer this. And 2 other OCT companies have since introduced it. Just next to it, you see Gentuity's HFOCT. And on the right, you see the deep OCT system, formerly from SpectraWave, but now from Philips, which incorporates AI in their OCT NIRS dual modality catheter. So this is all part of contemporary practice. It's commercially available today and will continue to evolve in the future and hopefully help with intracoronary imaging interpretation as well as utilization. So that's my comments on the AI. I'm going to shift gears in a moment to calcium. I'll pause for a moment just if there's any questions. And then the next several slides and studies I discuss are a number of calcium studies that have been published based on intracoronary imaging. Just open up if any questions. If not, I'll jump into the calcium. So many of you may know and may have heard of the rule of fives. So calcified plaque, as you know, it leads to stent under expansion. It's important that we address severe calcium and modify the plaque, lead to calcium fractures so that we can get adequate stent expansion. And all lesions, all calcium doesn't need advanced lesion prep with things like IVL or atherectomy. So when to use these advanced lesion prep tools is best assessed with intracoronary imaging. We've traditionally used what's called the rule of fives. You see it highlighted in the middle top table on the right for what features predict under expansion. And we've since refined this score to what we call the rule of threes. And this we found is actually more accurate and had better sensitivity and specificity compared with the original score, and more accurately can predict when we need advanced lesion preparation. So the difference, you get 1 point if the maximum calcium arc is circumferential, so 360 degrees. You get an additional point if you have at least 3 millimeters of calcium where there's 3 quadrants of calcium, so greater than 270 degrees. And then 1 point for if the minimum calcium thickness is at least 0.3 millimeters. 2 or 3 points, it's recommended to do advanced lesion preparation. So this was recently published, and this now is what we're using in our calcium algorithm. If it meets the rule of threes, we proceed with advanced lesion preparation. Now, a couple of interesting studies focused on calcium. This was a small study, but a randomized controlled trial looking at the impact of OCT compared to angio-guided PCI in Europe. And this showed the value of OCT guidance in treating calcified lesions with the OCT. What they looked at was MSA, so minimal stent area. They looked at percentage of patients with an inadequate MSA, so MSA less than 4.5 millimeters squared. It was only in 8% of patients in the OCT guided group compared with 36 patients who were randomized to angio guidance. So we know that post-PCI MSA was significantly larger in those getting OCT compared with angiography. And then when we looked at some of the procedural features, what's interesting is procedural duration, no difference with OCT or angiography. Fluoroscopy duration, no difference. No difference in contrast. So a lot of times we hear these myths that imaging takes too long or too much contrast. And yet again, this is another randomized trial that showed no difference in contrast or duration of procedure with OCT, and of course, a larger MSA or minimal stent area with OCT. This was from the EuroPCR public presentation, but it was published this past year in JAMA Cardiology.
But this is very important also, Evans. I mean, I don't use OCT because we don't have it, but this is a good argument about people who don't want to use OCT and CKD patient. It looks like the difference is the same. Um, but
Yep.
also, I think with the caveat that this is a high user, efficient, and also very skilled OCT operators.
Yeah, in this population they had okay renal function, but it's there are some novelties that are coming down the pipeline with quicker pullbacks. So the newer OCT
Mm.
companies with Gentuity and SpectraWave allow a 1 second pullback, so you can do it with saline. You can get great OCT runs with saline. In the near future, Abbott may be updating their system so that they can have something similar as well, something to look out for. But there are more and more iterations that are allowing us to use less and less contrast with OCT. And if you change the way you do your procedure, so if you do the same angiogram you do without imaging, and then you add
Mm.
OCT, it adds contrast. But if you change the way you do
Yeah,
your procedure, no, I'm taking a 360-degree view inside my artery. So I don't need orthogonal views. You can actually use less contrast that way with OCT. So
great.
this was just a mechanistic study that we published, just looking at stent edge hinge movement in calcified lesions, and found that that's actually associated with increased prevalence of calcified nodules. There's growing there's growing interest in calcific nodules and how to modify it and recognition of it. But this was just interesting that we found when we retrospectively looked at over 800 patients, we found that there's significant increase basically at the stent edge for calcific nodules. So when we're looking at ISR and where these nodules are forming, just something that's worthwhile to look out for. Just continuing the conversation with nodules, this is another intracoronary imaging study looking at OCT that we did, looking at the impact of two different calcium modification tools, intravascular lithotripsy with shockwave or orbital atherectomy. And what we basically found in this OCT assessment specific to calcific nodules, there were similar outcomes for areas, similar outcomes for target lesion failure. So they're comparable. The key is we need to modify the plaque. It doesn't matter how you do it, as long as you get good calcium modification, you get good areas and reasonable outcomes down the line. In practice, though, this translated to more IVL for us. And the reason why, Orbital is effective, but IVL simple, easy to use, and safe. And as a result, we use that typically now as more of a first line therapy for this. It has led to reduced orbital atherectomy, but there's still clearly a need and indication for atherectomy. And that's basically what the Eclipse study showed, is that when you need it, it's very effective, but most of the time you can get away without an atherectomy approach. Continuing the conversation with calcium, lots of publications with OCT and calcium this past year. This was a sub-analysis from the Illumian 4 randomized controlled trial specific to calcified lesions. And they were looking at the impact in calcific lesions. And what they found, if you see on the bottom right, there was an improved results at 2 years in patients who've had OCT compared with angioguidance in the calcific lesion subset. So there was less target vessel failure, less MACE, less MI, stent thrombosis, reduction of 89%. So really just highlighting the role of intracoronary imaging with calcium as seen in the Illumian 4 randomized controlled trial. And then finally, I alluded to Eclipse, but Eclipse was a randomized controlled trial looking at the value of orbital atherectomy compared with traditional angioplasty in calcific lesions. That was the main Eclipse trial. This is a sub-study that they did looking at the role of intravascular imaging. And as you see here, at 1 year follow-up, patients who had intravascular imaging, regardless of how they were treated for their calcium, whether it was balloon angioplasty or orbital atherectomy, there was a significant reduction in target vessel failure at 1 year if imaging was used. So again, it doesn't matter how you do the lesion preparation, but you need to use the intracoronary imaging so that we could get our best results when we're treating patients with calcium. And this is the largest calcified study to date, randomizing over 2,000 patients with severe coronary calcification. And then finally, one additional mechanistic study. This was just an OCT study that we looked at factors associated with stent recoil and its impact on future revascularization. And on the bottom left, you can see essentially what we found: greater calcium arc at baseline and eccentric expansion were the features that were most associated with chronic stent recoil. Chronic stent recoil was very common, actually, in 21% of lesions that came back with target lesion, requiring target lesion revascularization. So it is something just to be aware of, and it's something that you'll only be able to accurately assess with intracoronary imaging in the cath lab. And then almost done, just three or four more studies that I think really were impactful and are going to shape the future. Again, this was Rick Velberg was very busy publishing this year. This is a different study. This is a sub-analysis of the fusion study that was led by Rick Velberg and Alan Jeremias. And they actually, what they did, so VFR, this is coming in the very near future. In the next couple of months, when Abbott updates their Ultrian software, there's going to be incorporation of this VFR or OCT-derived physiology, which is exciting to have a multimodality imaging catheter. And what they looked at from the fusion study, what the impact was in the Lumen 4 data set at this combined anatomical, morphologic, and physiologic procedural planning using OCT-derived physiology. And this is just showing a representative case example. But the key is this is coming before the end of the year. We will have these tools available where with a single intracoronary imaging run, not only do you get all your procedural planning and guidance from the intracoronary imaging, but now we'll get our physiology. And we can apply the physiology for determining, do we need to revascularize, yes or no? What's the optimal strategy? Where are good landing zones? And then post-PCI, looking at physiology of, do we need to treat that distal lesion? Do we have underexpansion that needs further post-dilatation? So I think this is going to help further optimize our procedures. The ability to have physiology in every single case that we do intracoronary imaging will improve our procedural guidance, but it's also going to hopefully increase utilization of imaging further, because in your patient who's asymptomatic but has a positive stress test or has significant disease, but question whether or not they need to revascularize here, rather than reaching for your physiology wire, if you do an OCT, you get your physiology, you get your functional assessment, but you also get your anatomical assessment as well. So this is coming out in the very, very near future. It's been changed from a VFR to coined OCT-FFR, but this will be available very soon. I think very exciting offering. And that case example was recently published. And then in just the last three things to focus on, very interesting publication looking at the impact of intracoronary imaging in patients undergoing revascularization as compared with bypass. So on the top on the curve, you see that angio-guided PCI performs worse than bypass. And that's what we've seen. Trial after trial shows patients with left main or three vessel disease do better with bypass compared with angio-guided PCI. But what's interesting, when they looked at the patients who had imaging, intravascular imaging guided PCI, not only did they do better than the angio-guided PCI, they actually did better than those who had bypass. So it's a very provocative study. And I think it really shapes the future going forward. Again, this wasn't a randomized trial, but it's very provocative. Renovate complex PCI was randomized, but it wasn't randomized against bypass. These are matching the patients. But this is provocative because in the future, I think any PCI versus bypass trial has to be putting forward our best foot and should be looking at imaging-guided PCI when we're comparing against CABG. And I think that's the way where we'll start to beat them on outcomes if we're showing our highest quality PCI. Now, our second to last study, before I wrap this up, is another interesting study. This was a sub-analysis from an Octavis trial, which looked at OCT and IVUS in nearly 2,000 patients. And what they looked at was the impact of optimized outcomes versus non-optimized outcomes. And as you can imagine, if you were able to achieve the optimized criteria, it was associated at 3 years with less adverse events. But what's interesting, here they found the OCT arm actually optimized OCT led to the best outcomes at 3-year follow-up in target vessel failure. So interesting sub-analysis from the Octavis trial. And then I think one of the most notable studies published this year, this looked at pooled cohort data from 3 randomized controlled trials, IVUS XPL, Ultimate trial, and IVUS ACS. So 3 very large IVUS randomized controlled trials in over 6,000 patients. And what they found here, they were looking at different MSAs to see really, does it matter optimized versus non-optimized stent expansion, and what really leads to the best outcomes. And what they found, what the investigators found in this pooled analysis of 3 large randomized controlled trials, if you focus on the top right box, if you can achieve an MSA or minimal stent area of at least 5.5, and then in the green, the IVUS defined optimized stent expansion criteria was met. If you achieve that, that was what's associated with the best long-term outcomes. You see really favorable long-term outcomes with a 1% target vessel failure. So this is what we're after. This is what we're trying to achieve in practice. So MSA of 5.5 is a good rule of thumb. Oh, and then some little bonus stuff, just getting beyond intracoronary imaging, and then I'll wrap up. But I think it's important, just thinking ahead to the future. Intracoronary imaging, we validated that you can see similar to what we see in imaging actually in a CAT scan. I think this is the future. As important as intracoronary imaging is, we recently published that you can actually see the same stent measurements that we get with OCT, that high resolution with in-stent restenosis, you can actually see with a photon counting CT. So I think this is the future, using photon counting CT to determine a lot of this info and procedural planning before we even get to the cath lab. And again, just another intracoronary imaging study that we showed that all the mechanistic validation from OCT, Abbott on the left, SpectraWave on the right, of what the mechanism of stent failure and in-stent restenosis is, we're actually able to determine before you even get to the cath lab with a photon counting CT. So I think it's something to look forward to in the future. We're going to be seeing more and more about CT guidance and how that integrates with intracoronary imaging. And really, just to wrap up with the trials, I tried to show you some of the most interesting intracoronary imaging publications this past year. But as we look forward in 2026, these are some upcoming intracoronary imaging studies that will be published in the near future. They have yet to be reported, but something to look out for. And just in the next 2 months, the 2 that I'm highlighting in the middle are both late-breaking clinical trials that will be presented at ACC. So, hopefully I'll be back next year talking about the latest and greatest in 2026 trials. But as you see, there's lots of additional data in the near future that will help to inform us on the role of intracoronary imaging. So be sure to look out for that in the near future. And then maybe just a couple of minutes, 2 minutes to wrap up. I was asked to just highlight a case, and I thought this would be an interesting case. This is a patient recently that was referred to me. He has numerous stents, multiple interventions, has chronic refractory angina. You see there's a coronary sinus reducer, another device you're going to hear more and more about in the coming years for his chronic angina. But he's been having a progression in his symptoms, and he lives out of state. from us and presented to his local hospital, was cath. And this is what they saw. They attributed his symptoms to small vessel distal disease. Symptoms got worse. A week later, he was cathed again in his local institution and found the same thing. The stents looked great, but distal small vessel disease. And he called and decided to fly up to New York as he was having these progressive symptoms. And what stood out to me was angiographically, the stents do look great. But I decided, given his progression in symptoms, to do intracoronary imaging of the stent to get full evaluation and really be sure what's going on. And here you can see how rapid the pullback is with spectral waves, nears OCT, deep OCT. And what we found was surprising, the discordance between the angiogram. What you're seeing on the right in the cross-section with the spectral wave OCT is a lumen area of 1.9, which really is inadequate in a mid-LED. And here we can clearly see there's 3 stent layers. You have an area of 1.9. There you can just see the 3 layers. But when we look at the distal reference, so B is where there's an area of just 1.9. You have underexpanded 3 layers of stent. And distally, we're getting areas of 4.8. You have a stent diameter that's 3.2 distally, and a lumen diameter at the minimum lumen area of only 1.6. So this was something that we were able to more than double the patient's inflow to that small distal apical disease and really, I think, impact his symptoms. But the reason why I brought this just up as a case is the value of intravascular imaging. Angiography does not tell us the full picture. And I think it's important. You're bringing the patient to the cath lab. You need to listen to the patient's symptoms and do comprehensive assessment with intracoronary imaging. And particularly in stent failure, we don't get the full picture with an angiogram, and you really need to do further assessment with intracoronary imaging. So I'll wrap up just saying, in 2026, we need to change the question from when to image to when not to image. The default assessment, I believe, should be intracoronary imaging. So with that, thanks so much for your attention. I'm happy to open it up to any questions and further discussion.
Thank you so much, Dr. Shlofmitz. Phenomenal talk and summary. Questions came across is, do you think post-PCI physiology or imaging are more important in optimizing a patient with PCI? The question is PCI or physiology or imaging? Yeah.
Both pre and post, I think, are essential. There's no reason not to do both, in my opinion, as particularly of imaging. You purchase the catheter, so I think it baseline is very important because that's where you come up with your strategy, and you want to get it right up front. So if you have to choose, there's a lot of value to doing it up front. But I think it's also important post PCI because you want to check your work and see, are there areas of optimization, because it's often addressable. And to me, it's a debate that it's not either or. I really don't think there's any reason not to do it both pre and post stent implantation with intracoronary imaging. Physiology, I think what's interesting, something to look forward to in the year ahead, I think the world of post-PCI physiology will change in the next year. What we know from defined PCI is angiographically, we have a good result, yet a significant number of time there's ischemia at the time of PCI. At the end of the procedure, there's something that's addressable on a regular basis, and we can uncover that with post-PCI physiology. So as a result of the defined PCI's trial, Alan Jeremias and colleagues led the defined GPS randomized controlled trial, which has since concluded enrollment. They're in their follow-up phase, but I think in the next year, they may be sharing results of defined GPS, which really will inform us on our understanding of post-PCI physiology. So I think that is something to look forward to, but I believe once you have imaging-based physiology, like with OCT and in the next iteration with 3.0, this will be something part of routine practice. Look, the more data points we have, the better we can inform when to treat, because the reality is we don't get a perfect result every time. You don't get 100% expansion in practice every time. But the question is when to stop, when's enough? I have
Yeah.
78% expansion. Do I stop? And or do you keep going? And sometimes the enemy of good, you can cause problems if you're over treating. And when to stop, it's important. And using the synergy of imaging and physiology, it's great if you have those tools. I think it guides us to make the best decision for the patient for PCI. But why I absolutely recommend PCI at the end of PCI imaging is it guides after the cath lab. It guides pharmacotherapy, how long duration of DAP. Do you need PCSK9 inhibitors for non-corporate lesions that we didn't treat? And also, what
Mm.
quality PCI result? We don't always get a great result. And if you don't have a great result, it helps you knowing that so that your thresholds for when to bring a patient back if they're symptomatic. If you have 100% expansion, no residual disease, and the patient has atypical symptoms a month from now, probably not going to recap them, which is very different if you know that you have a protruding calcific nodule at the end of their procedure with an eccentric underexpanded stent. And that patient has symptoms a month from now, you're probably going to bring them back to the cath lab. So I think it really helps us for individualized patient-centered care. And this is now, becoming more and more the standard of care.
Absolutely. I mean, and the same thing goes to the case you illustrated just now in terms of like angiographically, this is a very, I mean, I wouldn't be honest with you, intervene or do anything, but now with imaging, you prove that this is something important. So the question is, when we see these cases, when you have somebody with refractory angina, right, and they have the stents or no stent or no intervention done and angiographic is perfect, do you recommend like routine imaging just to see in case there is some black burden that is invisible on angiography alone?
Yeah, it's this case woke me up too because I agree the angiogram looked good. And what happened? The only reason I imaged here, this is the patient had two prior caths within the month, and he flew up specific to have OCT imaging. Flew to New York for it. We had the discussion before, and I promised him. I said, the symptoms. I promised him I was going to OCT a stent so we could see what's going on. And I got here to the diagnostic angiogram, and it looked great. And we have imaging specialists here. And I remember when I asked for OCT, everyone's like, but the stent looks great. I go, well, you know what? At least we're going to document it for him and he'll have peace of mind and continue. And it was really surprising to me. And it really changed my practice because since then, I've been doing more routine intracoronary imaging when patients have stents. So I think the angiogram, we could get some information in de novo. But what I believe is with especially multi-layer stents, I think we're not clearly assessing the lumen with an angiogram, and I've increased my imaging. If they're asymptomatic and you have an angiogram that looks like that, I think we're done. But in patients with real classic symptoms, um, and the rest of their coronary anatomy is fine, I think it's worth a single, at least a one-time intracoronary imaging assessment of the stents because sometimes these are grossly under-expanded stents that we can address that with balloon-based therapies. So I do think with symptomatic patients and prior stents, it does warrant imaging if it's never been done. If you have from the end of the last cath, if you've done a post PCI IVUS and you see you have a good result and angiographically it looks good next time, you probably don't need to. But if you can't find, if they've all their procedures were at outside labs and you can't confirm that imaging's ever been done, I do think this has changed my practice, and I've been doing more and more imaging for that and finding a number of cases where there was discordance between the angiogram and the intravascular imaging.
Absolutely. Yeah, it's very mind-blowing. Final question, because the time is, you show some data on AI and artificial intelligence and machine learning. Where did this data come from? Like, and is there a way where there is a centralized process where all this imaging kind of funnel to the machine learning from different lab, different places in the country, or this is just a single center, high volume where generated this algorithm?
Yeah, so it's a good point. There's a number of different groups that are doing it right now. There isn't a centralized database. There are a few because largely it sits with just a handful of vendors. So with OCT, Abbott is obviously the leading vendor, so they have access to a lot of data. Due to HIPAA restrictions and various rules and regulations in different countries, though, there are some issues with data sharing, but Abbott has access to a lot of data with their AI. A number of the other vendors are gaining larger and larger access. So IVUS, for instance, Boston Scientific was the first IVUS company to have commercial AI. So the vendors, they're constantly retraining their own algorithms and improving their AI. But then there are third parties as well. So a lot of these studies that I mentioned here were performed by Rick Volberg and his group in Europe, where we were fortunate to have him spend a year with us at St. Francis. He was one of our advanced intravascular imaging fellows, but he is now back in Amsterdam, or in the Netherlands, where their group is leading a number of initiatives with AI in aggregating this data and trying to help improve this. And hopefully, as that expands, this will continue to improve AI. But there isn't one central use right now. But I think that's the future. I mean, we're seeing it. Everything in our life is being shaped by AI, and I think the chat GPTs, the Groks and the Claude, all this is infiltrated basically everyday use. So it's hard to get away from it. And I think it's exploded in at a speed that we can't even imagine or have predicted. So I think over the next 2 to 3 years, as all this data goes to the cloud, AI is going to help us in ways, just make us all better operators. You learn so much from it, and not only helps you with better outcomes for our patients, but it's certainly going to help our workflow efficiency.
Yeah, perfect. Well, Dr. Schloff, it's really very amazing and satisfying and also educational webinar talking about the importance and what is latest in imaging. What I learned from it is there's no excuse what not to image. And I remember you mentioned something in one of the conferences is if you're opening the end of letter to PCI, you should automatically, the cath lab staff should open the IVUS catheter or whatever imaging tool you have. So it's should be becoming a standard. And if you're not familiar with the process or the imaging, just keep doing more and attend lectures like yourself and other courses. But as you said, Boston and Philips and becoming with no algorithm, that definitely it's imaging for dummies, to say the least, to tell you how long the last lesion is, how bad it is, and where to land the stent. Uh, Very engaging. We have a lot of people attended. Thank you so much for your time. And if we have you in the future, we're definitely going to have you next year. Yeah, to have an update on the imaging. So I'm not sure the guideline going to move up more than 1A, but hopefully next year we'll have this acquisition from 15% to 44 and maybe close to 80 after the data presented. Thank you so much for your time and effort.
Always enjoyable talking with you, and thanks for spreading the word, and look forward to talking to you guys again soon. Have a great evening.
Thank you. And for our audience, thank you again for joining us. Stay tuned for the next session. Going to be third Thursday of the month. Next speaker will be posted in a week. Thank you for joining us and enjoy your evening. And if you are from the Midwest or East, stay warm. There's the school closed and there's a Arctic wave coming towards us. Have a good night.